My dear students, in this video, I am going to discuss the salient features of adaptive support ventilation, which is receiving wide patronage and is being viewed with renewed interest ever since the publications have increased. So adaptive support ventilation is one of those ventilatory strategies that can be beneficial in patients who are difficult to ventilate or difficult to wean. Let us start with a case. A 65-year-old male with severe COPD, gold stage 4, presented with acute exacerbation with pneumonia. The vitals reveal a respiratory rate of 34 per minute, heart rate of 118 per minute, blood pressure of 84 by 52 millimeter Hg, saturation of 90%, and capillary refill time of more than 3 seconds. Such saturation is on room air. The ABG shows a pH of 7.21, PaCO2 of 78, and PO2 of 54 mmHg on non-rebreathing mask at 6 liters per minute of oxygen. The patient was intubated and ventilated on VCV mode, but the problems that were faced included high peak pressures, hypotension, and ventilator dysynchrony. If you see this graph, you can see the pressure versus time, flow versus time, or the volume versus time. You can identify the progressively increasing end expiratory alveolar pressure, which is the intrinsic PIP, along with incomplete emptying of the expiratory flow still occurring at the beginning of the next breath, which is the gas trapping, and progressively increasing end expiratory volume, which is the dynamic hyperinflation. So all these are regular features in a patient of COPD who is on mechanical ventilation. And in this patient, how can adaptive support ventilation be suitable? So this question can be raised in the context of the problems faced during the ventilation. Now, in such cases of COPD, why conventional modes fail? If we look into the typical volume control ventilatory settings of 6 to 8 mL per kg, along with a respiratory rate of 18 to 22 per minute, what goes wrong is that the fixed respiratory rate plus prolonged expiration leads to incomplete exhalation, so for which there is progressive air trapping and rising auto-PEEP. So the consequences, of course, leads to hypotension, giving rise to reduced venous return, barotrauma, and severe patient ventilator asynchrony. We have to remember that always a high CVP in a COPD patient would not mean an adequate preload on the left ventricle, and that is how the hypotension occurs. That despite being high CVP, these patients are not able to breathe because of the auto PEEP. It leads to hypotension. Therefore, if you see in the PCV instead of VCV, there are still problems because here also the clinician sets the respiratory rate and the pressure targeted breath with short expiratory time is delivered, and the tidal volume may fluctuate unpredictably with resistance changes. So the result will be persistent dynamic hyperinflation, unreliable CO2 clearance, and frequent need for manual respiratory rate adjustments and the IE ratio adjustments. So we have to know the Otis principle upon which the adaptive support ventilation is based. The Otis principle states that for any given minute ventilation, there is an optimal combination of tidal volume and respiratory rate that minimizes the total work of breathing. There are two components. One is the elastic work, which is performed during the lung and the chest wall stretch, which increases with larger tidal volume and is dominant in stiff lungs, particularly in ARDS, pulmonary edema, etc. In fact, ARDS is also one form of pulmonary edema. And the resistive work, which is because of airway resistance, which increases with the high respiratory rate. And this is dominant in obstructive diseases like COPD or asthma. So these are the diseases where the airway resistance is high. And if you look into this diagram, which with work of breathing along the y-axis and the respiratory rate along the x-axis, you can see that this is a U-shaped curve, where on the left side indicates a low respiratory rate and high tidal volume, which means an increase in the elastic work, and the right side, a shift to the right side indicates high respiratory rate with low tidal volume, which is indicative of an increased resistive work. And the bottom of this curve is the Otis optimum, or the optimum work of breathing. So if you want to reach this bottom somewhere here, so it is this point you will have to choose. So adaptive support ventilation is unique because it applies this principle mechanically in the ventilator. If you look into the Otis principle in different ICU phenotypes, if it is a COPD or an obstructive airway disease where the resistance is high, the expiratory time constant is prolonged, the Otis predicted pattern would be a lower respiratory rate and a moderately higher tidal volume with longer expiratory time. Now, this is important because the necessary to prevent dynamic hyperinflation, autopeep, and hemodynamic collapse. In ARDS or in low compliance lungs diseases where the elastic work is increased and the compliance is reduced, the Otis predicted pattern would be a lower tidal volume with a higher respiratory rate, which gives the lung protective ventilation and thereby limiting plateau pressures and the volute trauma. In normal or recovering lungs, we require a balanced mechanics where the Otis predicted pattern would be moderate tidal volume and moderate respiratory rate, and that ensures a smooth transition to spontaneous breathing. When ventilation becomes harmful, it is often because we are working against this Otis principle. Now, how adaptive support ventilation uses this Otis principle? It measures compliance and resistance breath by breath, calculates the respiratory rate and the tidal volume combination that achieves the target minute ventilation, minimizes the work of breathing or reaches the Otis point, and automatically shifts when the mechanics change. For example, in COPD, we know that the resistance is high. So the adaptive support ventilation will try to reduce the respiratory rate, increase the expiratory time, reduce the auto-PEEP, and therefore it will also improve the hemodynamics. In ARDS, the compliance is reduced. So here the adaptive support ventilation tends to reduce the tidal volume while increases the respiratory rate and lung protection is preserved. So if we wish to compare conventional mode against the adaptive support ventilation, which follows Otis principle, we can look into four aspects where they differ. First is the respiratory rate selection, which is fixed by the clinician in conventional modes, but it is calculated by the ventilator based on this principle in ASV mode. The relation between tidal volume and respiratory rate is arbitrary in conventional mode, but it is physiologic in adaptive support ventilation. The response to mechanics may be delayed or have to be made manually in conventional modes, whereas it is continuous in ASV mode. And the work of breathing is often excessive in conventional mode, but it is minimized in ASV. So why ASV improves hemodynamics in COPD? The most important factor is a control of the respiratory rate. ASV selects a lower respiratory rate based on the resistance, which prevents breath stacking and reduces the mean intrathoracic pressure. Next, it causes expiratory time optimization and allows near complete exhalation, if not complete, for which the auto-PEEP falls and the RV preload improves. And the third, it reduces the need for sedation. So there is a better synchrony and less hypotension due to the effect of sedatives. If we look into this study, which was published in Chest in Kirakli, a randomized controlled trial comparing ventilation duration between adaptive support ventilation and pressure control assist ventilation in medical patients in the ICU, we can find from this study, which compared the weaning duration, the total mechanical ventilation, the intubation free days, mortality, everything, it has been found that the ASV may have a positive impact on preparing patients for weaning by shortening the total mechanical ventilation and weaning duration with a fewer number of manual settings of the ventilator. This is another very useful meta-analysis which was published in the Journal of Cardiothoracic and Vascular Anesthesia. And this meta-analysis included 11 randomized controlled trials with a total of 1,027 randomized patients. And the trial sequential analysis was conducted to assess the result robustness. And in this trial, ASV was associated with a shorter time to extubation compared with conventional ventilation. Uh, while the ASV indicated improved early extubation rates, there was, however, no significant differences in reintubation rates or length of ICU and hospital stays. So this meta-analysis also concluded that ASV appears to facilitate a shorter time to extubation in post-operative cardiac surgery patients compared to conventional ventilation, and this may suggest benefits in accelerating the weaning process and reducing the mechanical ventilation duration. And when the duration of mechanical ventilation is reduced, the complications of mechanical ventilations are obviously reduced. Now, this is another very important study which is currently started, and this is the post-operative intelligent adaptive support ventilation in cardiac surgery patients, the POSITIVE 2 trial. And this is the first international multicenter randomized clinical trial designed to confirm that post-operative intelligent ASV is superior to non-automated conventional ventilation, and secondary to determine if this closed loop ventilation mode reduces ICU team staff workload. So very important. So we will wait for the study to complete and the results to come out. Let's look into this case, case 2, a 55-year-old male of septic shock with evolving ARDS. In day 1 of ICU, the patient is having increasing oxygen requirement with bilateral infiltrates on chest X-ray. The PF ratio, which was initially 180, has come down to 140 within 6 hours. The compliance is rapidly falling. The vasopressors are continuing in mild to moderate dose, and the sedation assessment that is deep because the RAS is -4. In conventional approach, if you use volume controlled ventilation, a fixed tidal volume causes a risk of high plateau pressures as the compliance worsens. And if instead we adopt a pressure controlled ventilation, then safer pressures but a variable tidal volume risks the patient of hypoventilation or hyperventilation. The advantage of adaptive support ventilation is that it automatically selects low tidal volume plus higher respiratory rate when the compliance is poor. And it keeps ventilation with lung protective strategy without frequent manual changes, which may be necessary. And pressure limited breaths reduce the barotrauma risk. So these are the various important advantages of ASV. Let us see the third case. A 50-year-old female of elective abdominal surgery has improving sensorium with minimal lung disease. The conventional approach is to switch from pressure control or volume control to PSV and then to spontaneous breathing trial involving multiple steps. The advantage of ASV is that it can cause automatic transition from control to assist breaths, along with gradual reduction in mandatory support as the patient effort increases, and it works like continuous built-in spontaneous breathing trial. So the clinical gain from this would be an earlier recognition of weaning readiness, shorter weaning time, and reduced ventilator days. Coming to the last case, the case 4 is a 30-year-old female of OP poisoning, organophosphorus poisoning, who alternates between deep sedation and spontaneous breathing. The issues with the traditional or the conventional modes will be frequent alarms and over or under assistance when the patient effort changes. The advantages of adaptive support ventilation would be breath by breath adaptation to patient effort. It can maintain target minute ventilation despite variability, and there will be less dysynchrony because there will be no sudden over assistance. So the clinical gains would be a stable gas exchange, fewer alarms and interventions, and better comfort scores. Therefore, if we try to figure out the key advantages of adaptive support ventilation over other modes, if we compare to VCV, it is pressure limited, so safer in poor compliance, and automatic RR to VT adjustment can be done. Compared to pressure control ventilation, it is guaranteed minimum ventilation is possible and better control of PCO2 can be done. Compared to SIMV or PSV, it is continuous closed loop adaptation, so causes faster and smoother weaning. And compared to APRV, it is easier to apply and less clinician dependent, so it is better to non-ARDS mixed population. There have been several studies showing that faster weaning times, fewer manipulations with ASV, and fewer alarms were compared to conventional modes of ventilation is possible. So there are certain advantages as well as certain disadvantages. Like we know the advantages now, we should also keep in mind the disadvantages. The disadvantages are it does not allow direct programming of the tidal volume, respiratory rate, and I ratio. There is limited experience in pediatric patients. The operation algorithm tends to ventilate with low tidal volume and high respiratory rate, and that it is only available in Hamilton ventilators, but that is no longer valid because now there are some other ventilators also where we have ASV. But definitely the advantages are much more than the disadvantages, and these advantages are versatile, and the ventilator is versatile and extremely safe to use, and it is virtually possible to ventilate all intubated patients actively or passively, prevent dyspnea and auto-PEEP and dead space, less need of human manipulation of the machine, decrease time on mechanical ventilation, and adjust to patient's respiratory effort. So finally, my take-home message on this account would be adaptive support ventilation is most advantageous when lung mechanics are changing rapidly, patient effort is variable or unpredictable, the staff workload is high, and frequent ventilatory adjustments are impractical, and the goal is early and smooth weaning. ASV is less ideal when there is need for strict tidal volume targeting in severe ARDS with prone or ECMO, and when the clinician wants complete control over every ventilatory parameter. Thank you.